Land we love. Thank you very much. Morning.
Thank you very much, member. Okay, let me firstly just mention the apologies. There are a few. Um, Member Malahoo Fort, Member Golding, Member Dalrymple Filbert, and Member Horace Daly have tendered their apologies for being absent. Let me welcome other members who are here. Thank you very much for coming. And we had agreed last week that we would look at the budget or the expenditure so far for COVID-19. So I've invited the head of the National Health Fund, Mr. Everton Anderson, who is on the outside, and the permanent secretary and the CMO, who will give an overview, quick overview, and of course focus on the financing issues as discussed. All right, so there are the matters arising, the minutes of the meeting, sorry, for the last meeting are here. Maybe we could go right into it, and then I'll comment on some decisions that we had discussed we would get feedback on from members, to Zoom or not to Zoom, for example, once we go through the minutes. So the minutes are before us. Page 1. Page 2. Page 3. Page 4. Page 5. Page 6. 7. Page 8. Page 9. 10. 11. And 12. And finally, page 13. Matters arising, let me just quickly look at, raise the matter on page 1. Take a decision from there. I have here the results of the feedback. In support of Zoom meeting, we have myself, Member Malahoo Fort, Juliet Holness, Marisa Dalrymple Filbert, and Mark Golding. So that would be 5 persons of the 7 who responded. And in support of a Zoom and face-to-face meeting, we have Member Guy and Member Brown Burke. So no member indicated support for only a face-to-face meeting. So in light of the numbers, the Zoom meeting would have had 5 members supporting, and the Zoom plus face-to-face would have had 2 members. Member Norman Dunn and Horace Daly did not provide a response to this arrangement. So what do we do now that we have these numbers?
And I'm in support of Zoom meeting.
Chairman, I think numbers speak for themselves. The truth is that technically everybody has agreed that Zoom meeting, even those who would have face-to-face and Zoom. I think, however, that whereas we're all in agreement for Zoom meetings, there will be the occasion when we would like to have a face-to-face meeting, and I think we should always reserve that option, right? And on that matter, to Chairman, I think there's another matter related to that as it relates to the meeting component of it. I think right now in this particular phase, unless something material happens, I am recommending to the committee, subject to the approval of the other members, that we choose to meet on a 2-weekly basis as opposed to every week.
Okay.
Any better? Yeah. I don't know that we need to even meet every 2 weeks. I think we're at a place that we could meet once per month for updates, unless you're mindful that there is something important going on that requires us to come together as a team. I find our numbers are dwindling because though persons are still needing to be cautious and appreciative that COVID is with us to stay, I don't know that it is practical for us to continue to meet regularly to stay. So once a month, I think would be a good idea to pitch out there. So I guess we could put the suggestion of twice monthly and once monthly and see what the members vote on.
I'm for twice monthly, Chairman. I'm for twice monthly.
Any other member?
I would support every other week, twice monthly.
Every other week.
I would support monthly, considering that the situation seems to be handled and is being handled well.
I'm saying, it doesn't prevent us from meeting more frequently than once per month, because if something happens, then we would be called for a meeting, and that makes practical sense.
All right, so may I suggest that the idea of reserving the right to call more frequent meetings is something that we should maintain. As chairman, but also perhaps more importantly as the minister with responsibility for the portfolio presiding over the COVID response, we are entering into a fairly delicate stage with the easing of restrictions and the fact that the risk profile, if you will, of the COVID threat is going to change because our airports and are being opened up to a lot more persons coming in. There is going to be a need for greater surveillance. There's going to be likely less testing, given the numbers. So it's still a fairly fluid situation. In a sense, the dynamics are changing. So if members don't mind, I would probably be inclined to say at least once a month, but could be bi-weekly if necessary, depending on what is happening in the environment. Is that acceptable? That's acceptable?
Chairman, one of the reasons why I was thinking that the twice monthly would not have been a strain is because of the earlier decision as well, which is for the Zoom meeting. So what that also means, and the 14 days, I think you would understand why those of us who ask for it every 2 weeks would be what we're asking for. Given the same fluidity that we're talking about, given the question I asked last meeting, which we have still not answered, which is about the compliance of individuals with the stay at home for those who are coming in, which is also related to the risk and what to expect. I believe that it's not going to take that much of our time to just get that kind of an update for just those kind of issues, especially if we're talking about an online meeting.
So, for example, I would be prepared to say that unless something drastic happens, I would call the next meeting in 2 weeks' time. So it would be in keeping with that. But then after that, if things look like they're normal, I may say, unless something happens, it will be next month type of thing. So what I sense is that the committee is allowing for some flexibility, but very sensitive to the need to respond as the thing unfolds. And I think that's an acceptable position. So I thank you for the guidance there, and we note a decision on just being flexible, but ensuring that we have a meeting at least once per month. But the next one in 2 weeks' time, because of the unfolding circumstances around what is happening. The other issue, as a matter arising, was Member Golding's, where is it on the minutes? Member Golding had asked for I think it's on page 2, had asked for the circulation of documentation 24 hours before. I'm going to ask the CMO to speak to that when she comes, but my understanding is we probably would need to take an agreement, or we probably need to agree that for those documents to be available 24 hours before, we are not going to have the most current information. Because we get information twice a day. And normally the delay, as is in this case, is because up to this morning she was trying to upload information to be as current as possible. So if we allow for a 24-hour lag, then which means then it would allow for earlier response in terms of the information. But then you don't have the benefit of the most current data when you get to the meetings. Is there a comment on that, or is that acceptable?
Chairman, I hear you, but I would want that even though coming to the meeting we may have changes, because trends can demonstrate themselves even before coming. So I don't think there's any reason why we cannot have those, even though if the CMO or the PS comes and indicate to us that there have been changes with a few additions. And certainly, as was done at the last meeting, it flowed fairly freely and easily for us to understand.
Okay, so you're saying we should do the lag so we have the 24 hours. All right, noted. I'm going to need one too.
Well, the other part is also part of it, Chairman. The understanding that at the meeting we are discussing the most current data.
All right, fair enough. Okay, so if there are no other matters arising from the minutes, of course we have the presentations coming. Can we then move?
Minister, I was just wondering if there was a response to the question I had asked about the compliance for those. If it is in the report, that's fine, and if we don't have the answer, that's also fine, just to know where we are with that. Because I remember from the discussion that that is data that would need to come from JCF.
Right. So I'm going to ask
I just wanted to know
the CMO if she can answer that now, or she is going to respond in the report.
No, I don't have the information as yet, Prime Minister. So we have requested the information, and as soon as we get it, probably for the next meeting, we have it.
All right. Can we agree that we will circulate to members so we don't have to wait for another meeting to ensure that they get the information? Okay. All right. Any other matter?
There's one other matter, Chairman, just to ascertain whether the kits for the Cobas machine arrived on the day of the last meeting, as was indicated in the minutes here.
CMO.
We had expected to receive 20. We received 5 last week. So
5 translates into how many?
One kit is 192 tests.
And any idea as to when the other 15 would come, CMO?
We are told that we will get 25 by Monday. It was supposed to be by the end of this week to Monday, so we're still hopeful.
Okay.
Meanwhile, though, we have gotten the automated extractor for the use at the NPHL. We had gotten one for the NIC at UWI. We have now gotten one for use at the NPHL, and that will help us to increase the number of tests that we're doing by PCR on the open system.
Which means that the manual, you have less reliance on the manual method for the extraction, yes.
Okay. If there are no other matters arising from the minutes, I want to go into the presentations. I note that we have two presentations here. Are we going to be giving the general update first and then go into the COVID expenditure next? Is it up on the screen? You want to begin with the general update, then CMO, and then until we get it on the screen in the interest of time.
Right.
You have circulated copies, right?
Yes.
Okay, so can you just follow from your files?
Right.
Go ahead.
Morning again, members. For 9th of July 2020, we have 751 confirmed cases, of which 233 are imported cases, 39 remains at local transmission. All our new cases since the 1st of June have been imported cases or import-related cases, meaning contacts of those imported cases. We still have we're now at 236 contacts of a confirmed case, and you see that 42 are import-related. 236 remains with the workplace cluster, 7 under investigation. The new cases that we had yesterday, one from St. Catherine, one in St. Anne, one from St. James, one from Hanover, and 2 from St. Elizabeth, a total of 6 new cases yesterday. The updates on the other slides are pretty much just where we have been able to update the numbers, but essentially you would see that there remains pretty much the same if you go through the slide. So I won't bother to go through that again because, as I had said, all of 4 cases are really from the imported cases and not from we're not picking up any new cases from the surveillance that is being done in the hospitals and the health centers. And where we are picking up cases from the community surveillance, it's from the import-related cases. So we have done 27,357 total tests performed, and our positivity rate still is at about 2.7%. I think the rest of the slides remain pretty much the same, so unless there's any specific question, I don't think we need to go back through these.
There's just one difference, Pierce, and I'm sorry, CMO, and comes back to my comments last week. See, I moved psychiatric into 2 now instead of 1.
I've moved what?
In terms of psychiatric cases, from 1 in terms of comorbidities.
Oh,
to
the
2
comorbidities.
Now.
Right.
To 2 now.
To 2.
No?
What was the specific point that you?
No, I was saying last week that my view is that in terms of comorbidities, I don't think we should have included psychiatric cases, considering that 30% of the population generally have.
Oh. Well, these I understand your comment. However, it is important to note, that we do have diagnosed psychiatric disorders. So where it is that we have measures that need to be taken, if it is that we were seeing that we were having 50, say, that were diagnosed, then we know that our treatment and monitoring would be of a different nature. So it really does dictate how it is that we intervene.
Okay. Are there any other questions related to the report, most recent data? Just to say, while you look through and perhaps come up with any other questions, CMO, the decision or concern raised about getting these documents 24 hours before. Obviously, we have not done so this morning. What we agreed was that if we needed to submit the documents with dated data, not the most recent data, given that the delays are partly due to waiting on the most current, we do so and then just add the additional information verbally when we report, because members don't have the time to just go through and to make observations for questioning. So let's try and get that, approach it that way.
My apologies, Minister, to the members.
Do we have the other report up on expenditure or financing? Can we get that up, please?
Yes, Minister, that report...
You have it on the screen? Because I think that one is the substantial one that may benefit from. You wanna begin that? Members, you have any other questions on the updated report? No? All right.
The infirmary, I see that 255 were tested, 180 negative and 0 positive, which would mean that others are still outstanding.
Your voice is very muffled with the mask.
Yeah, this one is kind of heavy.
Yeah.
The infirmary residents, I noted that it's 255 tested, 180 negative but 0 positive. I'm not sure how long ago that was, if they're recent, and is it that the others are still pending? And
no, the results are not pending. The results have actually been received. This really needs to be updated.
I'm sorry?
It needs to be updated.
It needs to be updated.
They're all negative.
Okay. All right. Thank you very much. The permanent secretary will give the report, and then we have Everton, and this is from the NHF. And the permanent secretary is supported by the chief financial officer of the Ministry of Health and Wellness. So we have the full team here to answer any questions. I have a mental block, sorry. Just give your introduces. Donovan Davis.
Donovan Davis.
Sorry about that, Donovan. Yeah. All right. Thank you. P.S. Go ahead.
Thank you, Chairman. Members, good morning. Today we are, as per request of the committee, presenting the expenditure report for the COVID-19, for it's crossing 2 financial years. So we have to take that into account. So because we do cash accounting, we never usually report on 2 financial reports, but because of the nature of the expenditure that we have had to date, we're going to make this report across the 2 financial periods. Okay? So since COVID activities began of 2019, we have received from the Ministry of Finance and the Public Service approximately $4.7 billion to respond to the needs of the Ministry of Health and collaborating agencies like the National Solid Waste Management Authority and the Ministry of Local Government and Red Cross. The expenditure is outlined in the table, and you'll see that the majority of our expenditure was to the transfers to the regions where the operational expenditure occurs, or operational cost occurs for the implementation of activities. The next 2 major costs are the costs related to medical equipment and drugs. And those are costs relating to expenditure that would largely have been undertaken by the National Health Fund. So overall, we have spent approximately $3.9 billion, $3.97 billion, and we have a balance of approximately $702 million to be disbursed within the month of July. Based on this expenditure, however, I want to draw the attention of the committee to the impact that we have seen based on the activities that we have undertaken, where we have approximately 10 deaths with a mortality rate of approximately 1.6%. We have now 751 cases with 124 active cases. We have a recovery rate of 79.9%. Our hospitalization of 1.4%. We have 350 COVID beds mobilized in hospitals and an R0 of less than 1%. So we are making that outline in terms of cost impact to show that we are having some level of success in terms of the activities that the amounts of resources that we have provided to the regions and all of the collaborating agencies have had. But there has been some reallocation that has taken place in the supplementary estimates, and I wanted to just allow the committee to see those reallocations and to understand the strategic approach to the reallocation that has occurred, where there really has been a reprioritization of the key activities within the ministry to focus on the current risk profile for health and to redirect existing capacities to address the crisis response. However, also the budget adjustments have sought to respond to the clinical work program for COVID-19 and to provide support to the clinical supply chain, the critical supply chain for all medical goods, pharmaceuticals, and commodities. We have also had to do some major infrastructure adjustments to respond to the hospitals and the need of the hospitals for infection prevention and control, which has resulted in us redirecting resources for our capital program so that we have had to compress some activities. Some activities have had to be delayed, and we have had to cancel some activities in terms of the works that were projected over the financial year. And of course, we recognize the importance of the human resource in the effectiveness and efficiency of what we need to do for the success of the program. And so we have to find innovative and very new ways to engage and motivate staff, build capacities where necessary, and to augment where necessary. Based on that, several activities within the ministry have had to be adjusted downwards. So for example, on the human resource management, we have had to decrease by $113 million, but we are accommodating that because of the decrease in overseas travel. And so we are realizing some amount of adjustments based on savings. Although we are adjusting our technical support by $500 million, it really represents a redirection of the resources in technical services to the COVID response. So you'll see here that the majority of the adjustment downward is for the $1.2 billion for delivery of health services, and that is primarily within the regions. However, you will note that because the regions are the main operational engines for health service delivery, this really just represents a reprioritization of the activities at the regional level for COVID response. So in truth and in fact, although it is a reallocation in the budget line, it really is just representing a redirection of resources into the next slide, which is the COVID response. And so overall, we have received from the Ministry of Finance in the supplementary an additional $4 billion. And then we were asked to reallocate within our budget approximately $2 billion. So what you'll now see is that an overall increase for a new activity 10668, a new activity called COVID response. And that activity now covers all the objects and supports the COVID related activities and resources that we provided to NHF, so resources that we provide to all 4 regions, University Hospital of West Indies, etc. We have also had to do some adjustments in our capital program. So our capital projects that are there have been adjusted downwards by some $642 million. And that adjustment downwards is primarily due to delays that occur with the advent of COVID that prevented certain critical path items from being implemented during the financial year as was projected, and therefore the expenditure aligned with those critical path items would not be able to be realized within the period. However, the COVID response, as you know, the WHO PAHO recovery program requires that we have a recovery plan. And the public health recovery plan requires that we define some areas of work and that we cost those areas of work. How do we build back stronger and better and more resilient in terms of the country's health systems? And the plan has, as was discussed before, has 8 components to it: legislation, coordination, surveillance, human resource, lab systems, points of entry, meaning border points of entry, health facilities preparedness, and of course, risk communication and community outreach. The costed plan is approximately $6 billion, and we are intending to implement over 80% of this plan within the current financial year. The implementation of this plan has already started to a large extent, and several of the activities that are defined in the plan have already taken, has already been initiated, to include the community health aids, the retrofitting of hospitals, the purchasing of PPEs, private personal protective equipment, etc. All of those, and the strengthening of the surveillance and lab systems, all of those activities have already started, and to a large extent, we have begun the process of implementation. So that represents the report, and Mr. Chairman, I'm available for questions.
Chairman. Thank you.
Would you like the NHF to make their presentation and you get the full sum, or you want to go one after the other? Okay, all right, no problem.
Thank you very much, PS. Thank you, Mr. Minister. Just for my own information, you have gotten $6 billion additional from Ministry of Finance.
In the supplementary.
In the supplementary.
It's $6 billion.
No, we had 4 new money.
Yes.
$4 billion new money, but 2 are reallocation.
That's correct.
Right, across the ministry, in the ministry's original budget. And you have indicated that you have spent 2.5 billion so far as of July 6.
Go again, sir. Sorry.
Based on your first slide, you have spent so far 2.5 of that 6 billion.
No, man, 3.966.
Huh?
3.966.
3.9.
We spent.
Oh.
We spent 2 billion in 1920.
No. And that is where I made for this financial year.
Exactly. So we have.
So the 6 billion is for this financial year.
For this financial year.
Right. I'm not referring to 1920.
You're correct.
So you have spent
1.9.
1.9.
Yeah.
It would have helped, Pierce, if you had put in terms of the percentages here to indicate that the 17.2% down below there is not a part of the total percentages. It gives the impression that if you add up all of this, you get about 117%.
No.
I know, but I'm saying just for the appearances, it
Fair
would have
enough.
been ideal to indicate that this was just a percentage of what was expended so far. And then at the bottom, the other 17.5% is the difference between what you got and didn't spend so far, you know?
Okay.
So you're saying basically that in terms of what is left in terms of your budget, you have for this fiscal year about $4 billion left to be spent for the program so far, and you think that this is sufficient, Minister? I mean, I know you can't speak definitively to that, and what may happen down the road is that there may have to be another supplemental to do something. But I note here, Minister, and I don't know if you're in the Parliament the night when the Prime Minister spoke about the costing for food and accommodation, and it was indicated that it seemed a little high in terms of the amounts that was spent. I see here you have accommodation for this year, or for a total of almost $500 million, and food was well, include that then, almost $500 million for food and accommodation. And this is for the hotels, it is for the other government facilities, such as the one uptown and the one downtown or midtown, whichever way you want to put it, Minister, plus the others across the island. So that is basically where we have had those expenditure. Just for completeness, could we get a sort of picture of this amount and how many clients accounted for this?
So let me just get clarity. You want me to know, disaggregate this number by space, by individual space, and say how many persons have, what's the throughput of these spaces? So if we have a facility that has been in operation since, say, March, how many persons have gone through that facility since March? Okay.
Any other question? Anyone? No? Member Holness, you wanted to say something related to the budget?
I'm sort of struggling to appreciate the value of that information in terms of whether or not we're trying to do an assessment of each facility and what each facility costs, or are we in a place of trying to determine how much it costs for one individual coming through the government system wherever they have been placed. And I think it is more practical for us to have an appreciation of how much it costs for each individual to be housed, to be quarantined by the health facility over the duration of the period. So I think it's supposed to be very challenging, and I'm not so sure how practical the information would be to be analyzing uptown, midtown, and downtown vis-a-vis how much does it cost the government to house one COVID or suspected COVID patient.
Right. If I may,
Okay.
if I may, Chairman, my request was born out of the fact that the significant amount that was spent on the North Coast at the respective hotels. And I was trying to find out in terms of cost effectiveness, which would have been hindsight even so, but moving forward, where will you get better bang for your buck?
So if I may, from a policy perspective, the early stages of the COVID risks were addressed in a manner that included a heavy weighting on institutionalization of persons who were either suspected to be positive or positive. So we weighted heavily in an attempt at controlling the spread. And if you noted, remember, you would have heard me say that a big part of the strategy in the early days was to minimize through major containment the spread. Firstly, by preventing it from coming in, which is the border protection, border closures. And then once we identified cases that were in, we quarantined, isolated, suspected or otherwise. That would mean, therefore, a heavier cost in terms of housing, because those institutions that we had to establish, in some instances retrofitting them, in other instances, of course, expanding the numbers. When we went to the North Coast, we basically took over hotels or had agreements. We did get some support from some entities that didn't charge, and for the most part, they weren't charging. They really were charging for the meals and some of the other services. Now that we're going to a stage where we will see a slightly different approach, weighted more towards home quarantining, persons coming in and being required to stay at home. And in the case of non-nationals or tourists in particular, them being quarantined, at least for now, and that's not the term we use, but they're asked to stay on property or in the corridor. The need for that type of mass institutional government holding area is not as great unless we have major issues, and that's why the budget is so difficult to predict, as I think you've shown some appreciation for. So I don't think there's a problem in giving a breakout. Just to say that the numbers per person could be done, but it doesn't. You may have a wide variance from one person to the next because the virus exists for longer periods in different persons depending on all sorts of variables. So you may have one man spending 3 weeks in quarantine, and you may have another spending 14 days. And the cost implications there vary. So, that would have to be borne in mind. But the heavy cost was because we thought from a risk management perspective we needed to heavily weight the institutional holding areas, given the need to control the virus.
Chairman, thank you very much for the context that you have set, which is important once we come to look at the answers that will be given to the questions raised by Member Guy. I also want to suggest to the rest of us, though, I always feel so uncomfortable when individuals have asked questions and we seek to justify the question that is being asked. I think all of us are here, and as we get the information and we are thinking it through, there are some questions in our minds and we ask them just to get clarity in terms of understanding. And I think we should always give validity to all the questions that are being asked and assume that we are here really asking for clarity to get a better understanding and for no other reason. So I just wanted to place that there. I was looking at the transfer to regions, and I know that there was some, and I was just wondering if we could, it being, as you had said, the major, the bulk, kind of biggest budget item there, a little bit of an understanding as to, I saw where you had done some redirection of some activities, which is good, but just kind of give a little bit more detail as to that as well.
Thank you very much for the question, member. So the region, as I pointed out, represents the operational arm of the ministry. And so most of the work that would occur for COVID would occur in the region. So the region would be responsible for the contact tracing and mobilizing staff to do that operation. The testing at the airports that was done and mobilizing resources for that. They would be responsible for the operations in the health centers and retrofitting the health centers to see persons who have influenza-like illnesses, retrofitting the hospitals to create those COVID wards, and so the infrastructure work that would have to take place to ensure that the hospital meets the infection prevention and control standards for infectious disease like COVID. They would be responsible for reorienting the staff and getting the staff dedicated to this particular activity. As you're aware, member, we, in an effort to strengthen the cadre of persons who would be willing to participate, especially in the early days when there was so much uncertainty around the disease, we introduced a special allowance or a incentive, and so those payments would be made through this these resources as well. So that is primarily what we utilize this for. And in the transfer to regions that we have there, we have the transfers that were made to the University Hospital of the West Indies, which for the most part was the hub of our critical care interventions for those patients who needed to get into ICU and HDU support.
Yes, a clarification here. You indicated that the transfers to the region included some payments that were done in the early days, but how do you differentiate salary as part of what was in here too?
Right, so the salary component now is salaries that were paid to the ministry to a large extent, and then we made so this for the salaries component we had some persons who needed to be paid we call it now sessions. So the sessional fees and the honorarium and all of those were transferred to the region separately to support those activities that we saw.
So you're basically saying that in terms of payments to medical and for the entire team, then it would be more than the 162 that is reflected here.
Yes, it was.
Okay.
Just to continue the clarification, member Guy had asked about salary, but there's also an item for stipend as well, which is separate. So if you could just make the differentiation.
Right.
Between,
so the stipend relates to the $3,000 a day that we paid to persons who work directly in COVID-related areas. So like persons who directly worked within the COVID wards, etc. Those persons, and they
being paid.
Go again.
Still being paid.
Still being paid. Still being paid.
I am sensitive to the fact that you're just seeing the document, so I'm not deliberately delaying, but well, I am deliberately delaying to allow you some time to go through.
In light of that, Chairman, and you're quite right, because that was where my mind was just at the same point, that it's a little difficult to digest what just came in just then. But while it is being done, I don't think, and we do multitask, that we could ask Mr. Anderson to do his presentation, and if there are any other questions that we need to...
I have one, if you'd allow me just to... I have one, last one that I'd love to do. For the cost recovery plan, I just wanted to ask, because we keep talking about a new normal, and that new normal is for everything that we're looking at. So I wanted to ask you, as it relates to the recovery plan, what are some of those areas, the priority areas, and the change, if there's a change in focus, or the weaknesses that have been made bare because of where we are and what's happening, and how that new normal that we are going to get to after the recovery would differ from where we were, and what would have influenced that. Yes.
So thank you for the question. So to a large extent, after every epidemic, the public health system must have a point of reflection. And we look at where within the entire system we must strengthen in order to build back better. And there is a framework that the WHO has developed that allows public health systems across the world to do that efficiently. And they provide you with certain tools that allow you to do the gap analysis and allows you to assess your entire system. And then they ask you to lay out that gap analysis in these 8 areas that we have defined in terms of Jamaica's own prioritization. And I will, if the CMO wants to add to this, I invite her to do so. Surveillance and laboratory systems are critical components of what we want to do in terms of strengthening. You would have seen, and much weather has been made of the employment of the community health aides, and the need to strengthen the community health aid program in order to carry out the community engagement, because we recognize that the success of the interventions have to be at the community level. And we currently have about 8,000 or so persons who are in quarantine within communities. And therefore the monitoring of those persons at the community level has to be driven by some sort of engagement through a surveillance system. But that is one component of it. The next component is the strengthening of the surveillance system in such a way that we create more automation in how we do surveillance. And so the entire apparatus of the public health system at the primary level, at the secondary level, and at the tertiary level has to be looked at in terms of how do we strengthen the surveillance apparatus to be less manual and more automated, so that information can be received in real time and decisions can be made in real time. Therefore, the overall strengthening of the computer systems at the clinics, very important. We have a number of clinics that have no internet access, have no computer systems. People are still using these huge registers that if you want to decipher information, you have to skip through pages in order to get the information that you need. And in the new normal, we have to move away from those types of operation. Our lab systems, as you know, have been significantly strengthened over since the last epidemic, since the last H1N1 Ebola coming into now. There has been significant improvements in how we do what we do at the lab. But there's still more work that needs to be done based on what we're seeing now in terms of the response that we are getting. How can we build back stronger? One of the ways that we can do that is the collaboration with the private lab system to build an integrated lab service that not only relies on the public system but the private system as well. Now, what does that require? We are doing that type of analysis to ensure that we have those two components of a more robust lab system that allows us to do more. We also have, as part of our priority, the whole risk assessment and our community engagement. You saw how we operated in Tivoli. You saw how we operated in Norwood. Those are aspects of the new risk profiling system and the new interventions in terms of the new normal. Identifying through surveillance where the hotspots are, engaging those hotspots through the public health system, but engaging the community and working with the key partners in the community to ensure that we get the control and containment of the epidemic that is required over time. CMO?
Right. Just to reinforce some things, I don't want to be repetitive where PS has said some things already, but the international health regulations really have been the framework under which countries prepare for disasters and for public health events. And there are essential core capacities that need to be built within country. And since Jamaica signed on to the International Health Regulations 2005, and since then we have been working steadily to strengthen the different areas, which include the 8 areas that PS mentioned. So the strengthening of the capacities is really to deal with biological events, chemical events, radiological events. And what we have done in seeing how we recover from COVID, we have looked at the areas, picked out the areas in relation to management of biological hazards. And there are evaluation tools. We've picked out the areas for strengthening, areas that we have been working on over time. But really over the last couple of months, we have seen real-time or deficiencies. While we have responded well, and it is because of the work that has been done in strengthening those capacities over the years that have really contributed, but having to deal with it real time, we recognized that there were some things that needed to be fast-tracked. Within legislation and policy, the Quarantine Act, so we have the maritime regulations, but we don't have the regulations to deal with quarantine on land. So this is and how it is that we manage persons who are exposed to disease. And so therefore most of the legal framework we have done under the Disaster Risk Management Act. And so we now need to look back. We had started the process, and so this is one of the areas that we are going to be working on over the next couple of months, to have the completion of the review that we had done of legislation and the upgrading of the Quarantine Act to bring it in line and to develop the new regulations that would deal specifically with some of the weaknesses that we now are experiencing. In terms of legislation and policies as well, we have done a lot of work in terms of the policies for IPC in workplace and all of that, and so we continue to do that. PS mentioned laboratory, and for years we have had the national standards to work on, that process of accreditation for all the labs, and to ensure that they report reportable illnesses. This is a weakness that we've had in our system, in that the laboratories where they do some tests, they don't report. So when we don't have a framework that say that they must report. And so that needs to be fast-tracked to be established, and then to develop the capacity. Many persons have asked for the private labs to do PCR testing, for example, but the labs don't have the facility to do it, and it's not just putting in a machine. It's an entire building infrastructure that has to have the necessary negative pressure spaces, positive pressure spaces, to allow for the containment of live viral particles. So we are looking to work with the private labs to see how it is that we can build that resource, so that when we have a national disaster like this, we can pull from a system, a network across the country. And then we're also looking at how it is that we strengthen our regional public labs to be able to participate in that. In terms of human resources, we see what we are doing in terms of the community health aides, but we're also looking at different areas as well. We saw coming out of dengue, where when we had a lot of admissions to hospital, it was difficult to do the monitoring within hospitals, especially with the shortages of nurses that we had. And so therefore, starting with dengue, but putting a little bit of acceleration on it for this year, we want to look at the upgrading of the patient care assistant program within the hospitals. And we've started to do that, and we're going to be fast tracking that to see if we can get the support during this year to increase that work on the ground. Because really and truly, if it is that we do end up with a huge surge in the number of cases, then it's the same kind of monitoring that we're going to be needing in hospitals, and we will have shortage of personnel to deal with that. We're also looking at our public health inspectors, because we know the community health team involves the medical officer of health, the public health inspector, the community health aides, and all the other different community health workers. So we're looking at different other persons within that team to see how it is that we build out capacity. In terms of surveillance, PS spoke quite a bit on that, and essentially the weakness that we have seen where in surveillance dealing with this is how do we get the information quickly, and for the role of our national surveillance unit to be more on analysis of data. So we had been working on that over time to see how do we strengthen that unit so that the majority of the information that they have to spend a lot of time physically going through is done through using of technology from you're in the field. So that from the persons are in the field doing the community work, the data is inputted in cell phones, tablets, it goes straight to the health departments, it is put together, sent to the national unit, and we're able to analyze the data. So that is what we have been working on and is set out for us to do. In terms of the other areas, for coordination, we have done a lot of work in terms of our Emergency Operations Center. You really do require the space, the technology, to be able to have so many people working, gathering data from all sectors of the health sector, all sections of the health sector, to be able to coordinate the responses. And we have spent quite a bit of funding in terms of enlarging the area that we're using, as actually a new space that we're using, larger space that we're better able to manage in. So in terms of coordination, we have that work that a lot of the funding has been spent already, but some more work to be done. Points of entry, that is one of the most visible areas in terms of responding to problems that are coming from outside, to be able to detect it early and to contain it right at the source. Isolation areas within our airports have been a problem. And with this response, we saw the weaknesses. We had put in some resources coming out of Ebola, but we recognized the weaknesses and the deficiencies in the comparison with the two airports, how they're able to respond in terms of spaces. So this year, we're looking at funding for expanding the isolation areas within Sangsters International Airport, for example, that has one isolation room, and to retrofit the NMIA facility to make it more fit for purpose. Health facility preparedness and response, we have done a lot of work, a lot of funds have been spent already in terms of we've put in 4 new isolation beds at fully isolation area at the Cornwall Regional Hospital that is up and working. And we have retrofitted areas within the Mandeville Regional Hospital. Within all of the southern region, they have done a bit of refurbishing on their wards to ensure that infection prevention and control measures can be practiced. And we look to increase that through especially our regional hospitals to ensure that we have all the necessary spaces and they're properly equipped to deal with these kinds of emergency. Risk communication and community engagement is a big area that we have to address going forward, because we have to be able to communicate effectively and continuously with the population. We know that during an epidemic, there's a peak where the population is like they've heard enough, and then after that, we start to go down. So we have to find new ways of communicating and make sure that the communication still remains relevant so that people continue to be sensitized, especially now when we are opening up and we have persons coming in. This is where the population need to have the highest level of sensitivity so that everybody has that responsibility. So right now we are changing a lot of our messages. A lot of new work is being done to look at how we communicate on the airlines when persons are coming in. All of that is still being done and being worked on now. So those are the 8 areas that we plan to do quite a bulk of work on this year, work that has already started and we will strengthen over this year. It will certainly enhance our response in this pandemic, but it will certainly put us also in a much, much better place when we have to respond in the future.
And I think one that you could add to that, Minister, in terms of number one, policy, this might seem a little humorous, but to look at the possibility of getting equipment from certain jurisdiction, so you have a multiplicity, so you're not tied to the idiosyncrasies of the behavior of certain elements.
Well, I won't try to interpret exactly what you mean, but what I will say more generally is that the approach to sourcing, whether equipment or material, isn't confined to any single space. It actually is a function of where it is available. In the early stages, the government of the day, working with the logistics experience of the NHF, would have gone to Timbuktu to find N95 masks and all the other protective equipment. So, because it was just not available, and where it was very expensive. There was price gouging taking place. So, we haven't really discriminated at all, but we have tried to get good quality material, yes, member, and wherever we could get it. So the policy is quite open in that regard. So there would be no need to deliberately outline that because it's already in place. All right, thank you very much. Okay, Member Dunn.
Yes. Thank you, Chairman. I know the PS and the CMO explained the surveillance side of the cost recovery plan. But I'm a little surprised that only 1% is dedicated to that portion of the cost recovery plan, because surveillance, as you both indicate, is a critical portion and part of the way forward. And therefore, I am wondering if a new look could be taken at that particular area to see if there's any way we can strengthen the surveillance portion of the recovery plan, because that is essential. Another thing I'd like to suggest in a number of pillars is maybe a ninth one, and maybe you would say it's covered in coordination, lab system, and risk communication, and this is infectious response detection, disease response and detection. And why I say that, almost to create an equivalent of a Jamaica CDC. I know you have a National Public Health Lab that does enough work on this, but something, an agency that is completely dedicated to infectious diseases generally, because going forward, as you can see, with travel, infectious disease is going to be of more importance to countries, and how do we mitigate against our local population being infected or affected by it. So I'm suggesting, as I said, maybe it's already rolled up in all these different areas, but if you go look at a dedicated infectious disease agency for Jamaica that deals specifically, I mean, you would have your constant linkages with CDC and other agencies around the world looking at new and emerging disease conditions and how do we prepare ourselves for that outside of the national public health lab that we have.
Right. Yes, it is kind of rolled up in what we're doing in terms of the lab. It's a very good point because, I mean, over the last 5 years, we have dealt with so many different infectious diseases. And we see even now as we deal with COVID, we see so many things that are emerging, right? So we are looking to strengthen. Right at this present time, we're not really looking at a separate laboratory framework because in terms of laboratory, a lot of things are joined up. And so the systems that we have in place, we are strengthening both at the National Influenza Center and at the National Public Health Lab. And really to the creation of the network of laboratories is important in how we move forward. But we take your point. We recognize that we need to have more dedication. Up to all of this week, the director of the National Lab Services have been speaking to me about building out more space within the National Public Health Lab just to dedicate to this kind of setup because we have so much to respond to. So I take your point. Thank you.
Okay. All right, so can we go now into the NHF? Mr. Anderson, is your presentation, you have a presentation for the table, just okay.
Not PowerPoint. Morning, Chairman, morning, members. We started the process of procuring COVID items on March 15, 2020. Some items we actually had started to procure from as early as January when we realized what was happening across the world. But to date we have spent 2.27 billion on items. And just to be clear that the procurement approach that we took involved firstly our local suppliers, but also going across the globe to see where our credible partners could provide items that Jamaica needed. And part of it had to do with sustainable procurement, meaning that items bought should be able to be used post-COVID. So you don't want to buy any piece of equipment that we've never used where you have problems with servicing. And I think so far we have managed to achieve much using that approach. For pharmaceuticals, the expenditure is 506 million. For PPEs, a little over 1 billion. And for major medical equipment, 742 million. With respect to PPEs, most of the items that we've ordered, we have been able to get in. We prioritize PPEs by creating a list of items that we work to have in stock at all times. These included 3M masks, surgical masks, exam gloves, nurses' caps, disposable aprons, face shields, hazmat suits, medical goggles, and overshoes. To date, we've been able to procure most of these items, with the major challenge being disposable gloves and N95 masks. But for disposable gloves, we had made earlier moves in January to increase our stock levels, and we do have supplies who are expected to deliver shortly. We also have been able to get examination gowns as well as impervious gowns. Impervious gowns not in the quantities that we would desire, because globally there are issues in supply and demand for these items. For the medical equipment side, we got a master list from the ministry approved by the CMO, and we've been able to procure most of the items on this list. In fact, to date, we've procured and have in stock either at the warehouse or at the facilities. We have procured and have in stock 83% of the items that we have ordered, with an expectation that by the end of August or thereabout, we would have received items from most of our suppliers, and the initial procurement cycle would have been completed. The COVID-19 pandemic is ongoing, so part of the plan is to ensure that stock levels are maintained to address what may come. So for the PPE items that we have prioritized, just to indicate that for most items we have sufficient stock on hand or on order that we expect to get. But the major item that we've had an issue with is the 3M N95 mask, for which most of our clinicians were fit tested. The current stock level in our warehouse is about 1,300 masks. And just to report that the challenge we've had is that we are procuring this item in what I would call a hostile procurement environment, from a risk perspective, from a logistic perspective, and from a price perspective. So these masks would initially cost anywhere between 69 cents US and $1. We've had quotations ranging from a low of $4 to a high of $10 US per mask. The other risk is unknown suppliers involved in the market, and we've had even persons who would normally buy from who have made orders, paid monies, and who have not received items. So we had to be particularly cautious in procuring these items. But I'm happy to report, though, that we have an ETA for these masks for tomorrow. We should get 160,000 pieces, and then we have other deliveries scheduled from a supplier who we found comfort with. So I think that's the major item that we are working on at this time in terms of creating a sustainable solution as it relates to the key PPEs that we have identified. So the work continues, and we are committed to ensuring that the country is supplied with the critical items needed. I'm open for questions. Thank you.
Thank you very much.
Chairman.
Question,
Thank you.
member.
Your budget here, Mr. Anderson, how much did the Ministry of Health and Wellness provide of this 2.27 that you have indicated here as your total expenditure to date?
Right.
Or to June?
As it relates to COVID, I think today would be nearing about $1.7 Donovan in that region. But just to indicate, member, that we would normally buy pharmaceuticals. So what we would have done from as early as January is start increasing supply levels for other critical items, especially for persons with diabetes, hypertension, and other conditions.
Mm-hmm. The second chart you had there, table, sorry. The cost that you have is the cost as per the quantities ordered. Okay. Because I've noted that in some cases you have not received any, but there is a
right. There's a commitment.
A commitment
right.
there. Mm-hmm. You mentioned about in the last part of your presentation about the N95 masks ranging from as much as $4 from as much as 10 to a low of 4. What have we bought them at?
Right. The mass that we are expecting tomorrow, I think the average price is about $4.50 per mass.
Did we buy any for 10?
No.
Okay. What's the highest we've paid in this hostile environment?
All right, so this is initially, remember what we did in January, we actually bought what was here locally in the island. So we got some reasonably good prices for those. But eventually there are no supplies in the country from local distributors. So this is the first major supply of 3M. That's 3M. Of 3M N95 masks that would be coming in. So this price is $4.50.
$4.50.
Right.
And you said we got some very reasonable prices locally. What were those reasonable prices like?
Right. I'm trying to recall, but I think it would be nearer to $1, but these would have been before pre-COVID. Right.
Before COVID. Mm-hmm.
Right.
Okay.
Hello? This one, something is going on with this, it's sort of broken. So I noticed locally the mass price moved from $100 to $200-300, then to $500. So I don't think the problem only resides with us here in Jamaica, because even internationally, as more and more countries were desirous of needing to have their citizens wear masks, you found the price of masks going up right across the board.
Comment on that, Everton.
Right. I think with the demand, remember, I'm agreeing that the prices we saw were alarming. And even now with the U.S. situation, we're finding that the prices are again beginning to trend up, which is why it's important that we're able to lock in the prices that we did for the 3M masks, because that I expect to rise again.
Thank you, Chairman. And this might not necessarily be your probably minister who would answer that, and we have had discussions about that, because there have been repeated more than once concerns among the hospital, and I've made it at this committee meeting before, about the logistic arrangements to get these particular equipment, the PPEs, into the hospital. I'm happy that you have indicated that the NHF has adequate supplies. So really, as Minister had agreed or concurred some time ago, sometimes we need to look at what happens in the local system to see that it gets out on a timely basis, and that the medical and nursing personnel are not somewhat constrained because they don't see or hear that it is coming in on a timely basis. So it is something that now that I am assured by Mr. Anderson that there is sufficient amount in the country, that the other part needs to be fine-tuned, Minister. Yeah.
Can I just comment on it? A couple of things. First of all, I think the NHF, working with the ministry, has done a good job, a fairly good job in securing PPEs for the country, and in particular, of course, for the public health workers. I mean, there was, in the immediate aftermath of COVID spreading into other countries, other hemispheres, there was a mad rush on PPEs, and the reality is that we could not have anticipated this kind of demand. So it's not that we had the inventory sitting down in a warehouse to respond. So we had to really pull all the stops out, if you will, to reach out to all the possible suppliers, as Mr. Anderson said, local suppliers in the first instance, NHF was important in that regard because they currently have these relationships from drug purchases and so on. And it did mean significant variance in prices due to shortages. And countries, frankly speaking, started to, hoard? Stock up on their own, for their own population, right? Many countries, not just, no particular country, many countries.
China did too,
Exactly.
In the opening remarks from the chairman.
Absolutely. In fact, some countries ordered their manufacturers not to export, supply only for the local market. In that context, I think we have done well, because I don't know of a case except anecdotally where health workers have been so out of stock that they could not do their jobs and feel safe. I've heard of cases of low supplies, which is understandable, particularly in some areas. For example, face shields, I understand, was a big issue. It was difficult to get face shields. We explored making them locally and eventually made some locally, just as we have been promoting the masks locally. But the reality is that for the health workers, they are accustomed and they feel more comfortable working with the approved, accredited manufacturers, because it's a very big safety issue. So even while we were making them locally or trying to get them made locally, 3M, for example, not to be promoting a brand, but 3M is what the doctors demand. That's what they want. And we had to stand in a line to get 3M products. Am I correct? So there's a lot of variance in terms of the thing. But generally speaking, I think we have been able to secure, and we are making arrangements to continue to secure it, because we want our health workers, our frontline workers, to be safe.
Sorry.
This question is for both the CMO and Mr. Anderson. CMO, there's a recent study in the UK that looks at the use of dexamethasone, especially for critical ill patients, and there are some preliminary results out on that. What is our position on that? And then the question to Mr. Anderson is, if this is in fact so, do we have critical supplies of that?
So the use of dexamethasone in persons with respiratory illnesses is not unusual, and it is something that we have persistently used, especially in our moderately to severely ill patients with respiratory problems. So that is pretty much a standard of care, for us. So I don't anticipate that where the doctors see the need for this, that there would be any hesitation to using it, especially now that it has been shown to be beneficial in persons that are moderately severely ill. And we have not really experienced any shortages where this is concerned. Mr. Anderson may be able to give more updates, but certainly we have not had any reports of shortages. We have not had many patients who have been moderately to severely ill, but we do understand that, we do have to have the supply in case it does happen.
Yes, I'm confirming what CMO said. The stock levels are pretty good at this time.
Okay, member?
That was part of the two questions I had, Minister, but I think it's a St. Mary thing, The other part of it, and PS, you're excluded from this, okay? All right. Just wanted to know, there was a time, CMO as well, that the whole aspect of hydroxychloroquine was mooted as one of the wonder drugs for this treatment. And there was a lot of national, and I don't mean our national, but across the world, activity to try and procure it. In fact, one state, one country actually, commandeered all that one other country produced. But if I recall properly, the NHF had indicated then that they had sufficient supply for usual uses of it, for the rheumatoids, etc. Question, that has not changed. We still have adequate supplies, and was there a rush, although I know you don't sell to the public sector, but was there a rush on demand for hydroxychloroquine?
Right. The situation is good for that drug at this time. In fact, we also benefited recently from donations out of India. So even with a slight surge initially, our stock levels for that drug, I think, is over 6 months supply. So it should be pretty good.
Right. And Minister, just one final, well, probably it's a final question. You indicated that, and Minister did too, that earlier on we sought to get from our local suppliers. The local suppliers mean the usual entities that we tender for our drugs, all of them. And you said that they came in quite, for those who had here, that came in quite reasonable for us. But you had to go internationally afterwards. The question that arises, you mentioned the hostile environment, and the hostile environment, I think you gave three concerns, one in terms of price, one in terms of the logistics, and the third one, I think, in terms of my coinage quality, right? How did we, or how have we able to deal with the third one that I just mentioned in terms of the product being of value and in terms of efficiency?
All right. The initial approach was to go to all local distributors for the major equipment, as well as consult with overseas suppliers, because we do business with companies across 80 different countries. So we wanted to provide a wide opportunity to get the best items. So we got good value for money, in my opinion, for the equipment, and for the pharmaceuticals we would have already had existing arrangements which we tapped into. And in fact, I think that is one of the reasons why the drug supply has been pretty good, because we bulked up on supplies in January and February. So the PPEs, I think, would be the issue in terms of the price risk, where the price really went to places that we had not previously seen. What we did what we call a midterm supply evaluation. So everyone who supplied items, every organization, we had a formal evaluation of items received, and we actually would have given, I think, over 90% of the suppliers a good grade. In instances where items were not appropriate, we would not have accepted those items. And I think one of the good things at this time is that we would not have had suppliers bringing in all their items at once. So if you had an order for, say, 200,000 items, the first 10,000 was bad, it means you then had to go back and create a better situation. So I think we have managed that risk by doing formal evaluations. Even items like impervious gowns, it would not be unusual for you to go to the warehouse to see the supplier, our team, and maybe a member of the KPH team actually having the gown and checking to see if it is indeed impervious given the environment. So I think the team has done a pretty good job in managing that risk.
Thank you very much. CMO, you want to come in?
I just want to make a note on the use of the hydroxychloroquine. While I recognize that Mr. Anderson said that there was an increase in demand for it at one time, it was never a part of the clinical management plan for COVID-19. We have said that repeatedly, and I think any increase in demand might have been from persons who are regularly on it for arthritic problems, wanting to stock up in terms of if it went short. I just wanted to make
I think
that
we
clear.
got that impression, PS, and CMO, not necessarily that it was part of, because you did indicate at one of our earlier sittings that this was never part of what, you know. So I think Mr. Anderson's allusion to increased demand was simply because of those who were on it never wanted to have a shortage. And I think I can speak for myself and my colleague from St. Mary that we understood it in that respect.
Thank you very much for that confirmation of collaboration from the members from St. Mary. All right, so members, you've heard the presentation on financing. I think it's fairly comprehensive. Always willing to revisit the issue. It is an ongoing issue. You want another question? Okay.
Minister, I understand, and based on what you said even in response to the question last week about the field hospital, that some of the equipment that you have ordered and not yet received but would still want, there is really no quote-unquote urgency in getting them, such as, okay, the ultrasound machines, you ordered 6, but it's only 1 you have gotten so far. And in terms of the ventilators, 32 down to 12. But they are still going to be had.
Yes.
That's the question.
Yes, and in fact, the ultrasounds I expect by the end of July. I think the only item that we have a longer term delivery plan is the ventilators, because that particular brand, the demand globally has surged. So the arrangement is for some ventilators in July, the remaining number in August, and by September we would have completed the delivery and receipt of those items.
Where are we getting these from?
It's a local distributor, Medical Link.
I meant where, the country of origin.
I think it's Ireland. Right.
The EU has been quite helpful, meaning the mission here, in helping us with some of those ventilators. We benefited a lot from the PROMAC program, a program that existed prior to COVID. And even though they were brought in some instances for the maternal care, mother and child care, the high dependency units, we have actually used some of those units to treat with COVID cases. So, you know, I guess, it's worth noting that we were lucky in one instance because those were already in train coming into the island. And it was a fairly substantial order. We added a few where we could. And so we were ready just in time, and therefore never had a shortage, if you will. Of course, in addition to the low hospitalization and critical care cases. So I think as a country, we're very comfortable where we are, and will be even more so in a few months to come. And, you know, because of certain agreements that we had prior to now. Is there any other question around financing? No? All right, can we move to any other business?
Thank you, Chairman. I just want to find out from the CMO in terms of the fact now that we have gotten some additional kits, the backlog in terms of the persons who, and the time delay in getting back the results for those who, as I brought up at the last meeting, were waiting for long periods, plus the concern that in terms of surgeries, that there had to be some delays. Have we overcome that particular hurdle?
We are still addressing the backlog because as we do, more samples are coming in. So we have still, though, for this week, we are prioritizing the samples from the hospitals and from the other surveillance in country. So we're really trying to get those out quickly. For the samples that we are prioritizing from the airports are the business travelers who we would want them to get their result quickly so they can do their business and be able to leave the country. And those are a minimum number of samples. We are processing samples from the airports daily, but our priority, the bulk of what we're doing now really is addressing the backlog from the hospitals and from the health centers and from any contact tracing that has been done.
Can I just, for the record, I think it's necessary, given the importance of this committee, that the purpose of the committee, that the issue of testing is going to have to, will see some changes, and has already started to see some changes because of a number of issues. The waiting on testing, which I know the country places a lot of sort of the response mechanism. See testing as perhaps one of the most significant tools has to be reviewed in the context of a more holistic approach to testing, to surveillance and management of the response. The reality is that as we lift restrictions on borders, more persons coming in, it is going to be practically impossible to test at our airports in the first instance, just not possible. 500 coming in as opposed to 2,000 or more. The sheer space at the airport wouldn't allow that testing to take place. But also importantly, the personnel that we have who have not been increased significantly because it is a specialized service to do most of what needs to be done and would take time, just would not allow an efficient operation. And so that adjustment to persons coming in is going to mean an adjustment to the testing protocol at the airport, some shifts to the health centers, but also a more targeted approach to testing based on the risk assessment around places where persons are coming from, but also the particular individual that is being screened at a particular point in time. What it would mean is that there would be a mechanism at the airport to do some testing, but not nearly the numbers, or sample collection, but not nearly the numbers that would have been the case in the early days. It would mean some of that sample collection would be shifted to the health centers. It would mean too that persons are going to have to comply more rigidly, and we have to continue to drive that message with the stay at home or home quarantine, and also to respond based on any particular symptoms that they have. They need to be self-motivated to call the doctor, visit the clinic, call the 888 One Love number, because that's when the testing would be triggered if they are staying at home during those 14 days and have issues. We have been having a lot of issues retesting. I want to just be very clear that the ministry, the government acknowledges that in the last week and a half, the approach to testing at the airport has been periodically fairly chaotic because of the numbers that are coming in. And we have had to make some adjustments to try and accommodate and to smooth out the backlog in processing of individuals, the transaction time to deal with those persons. But that backlog has also manifested itself at the labs where the actual testing of samples is to take place, which is why we're lagging so many days. And so the new arrangements are going to attempt to smooth that out, but it's going to require changes in that arrangement, greater surveillance, significantly more surveillance, a greater compliance from the populace, those who are to comply with the rules of stay at home or quarantine, whether they are nationals or non-nationals. And that messaging is going to have to be repeated over and over to get the population to come to terms with the realities that if we're going to go for more relaxation and normality, the risk profile is going to change and the approach to managing that risk is going to change. The pre-testing, which should have kicked in the 10th, we're not at the 10th yet, right? I think that's today, tomorrow, is still on, but I want to just say to the populace, to this committee, that pre-testing offers a limited guarantee around identifying a positive case. I do not want the population to think that pre-testing is going to guarantee that one who has done a test 8 to 10 days prior to coming in means that they are free of the virus. And that's very important, because the reason why that is important is that the message around surveillance and self-monitoring is going to have to be more important, because there are margins of error, major margins of error with pre-testing. It will pick you up if you're positive at a particular point in time and rule you out. So there's a positive there. But you could be carrying the virus and it doesn't show up because of the extent to which the virus multiplies. See, I got the right term this time, remember, from last week. And it may not. And so when you come in, the screening at the airport will take place, the temperature checks and the interrogation and so on. Assuming you're asymptomatic, you end up in a hotel or at home, you must comply with the other elements of the protocol, the distancing, the mask wearing, the staying in quarantine if that is the requirement, the following up with the health center, the calling the number. You cannot rely on the pre-testing to give you the type of guarantees that would make you comfortable or us comfortable. And that's really the new narrative that is going to become the dominant narrative as we move forward with the relaxation. Yes, Member Holness.
Chairman, I don't want to generalize, but I'm very concerned with Jamaicans believing that in every respect we need law enforcement to have us comply with what is good for us, our families, and the rest of the population. I have observed, particularly in my constituency, persons who are non-Jamaican who, when asked to stay at home, do not do so. So last Saturday night, I went to a setup and I saw 2 police vehicles there sent by the Ministry of Health to find a particular individual. We located him long after we went to his home. He wasn't there. And then we went back to the setup, and he was very much at the setup. He's asymptomatic, he's not moving. He was at the funeral the following day with a lot of persons. I would want to encourage Jamaicans, when people come from overseas, scorn them if necessary. If you realize that they should be quarantined and they are up and out, and they could tell me, he was at the gas station and I saw him with Master Joe, who is 80 years old, driving around in the car. And the guy was adamant, look, I don't have any symptoms and I am not moving. We need to take our health in our hands as well, because we cannot just depend on the state to enforce the law. We have far more citizens than we have state officials to do the enforcement for us. So I'm making a plea, because we would have had a situation where the number of funerals declined to almost nothing. We are now seeing set up grave digging and funerals abundantly every day, every weekend, 2, 3, 4, 5, 6 in a community. I am begging Jamaicans to understand that the persons who you know have traveled and you see them out, report, and at a minimum, keep your distance from them.
I think you have said it. It's very important, but I want to just add one other thing to what you and myself and others have said. The position of the government is that if persons do not comply, and I agree with you, we have had cases where it has been a cat and mouse game, unfortunately, as if it is some joke by some persons who have come in, abandoned the rules of our terms of engagement, which is the quarantining at home or stay at home, and even in cases where we have had positives, you can't find them. And even when they know you're looking for them, they're dodging you as if this is a joke. It's not a joke. And I just want to say that the law allows us to apprehend and to hold in a state institution persons who are so inclined not to observe the protocols or the rules or the orders that have been given by the government. And we are going to be vigilant in pursuing at least those who we can, given that we probably can't do it to all. And when we find them, we're going to have to take the strongest action to ensure that persons recognize that this is very serious. It is about protecting a country, your families, your communities. But the point I wanted to make was that the government has always said, the Prime Minister, myself and others have always said that the government will pull back on some of these measures, relaxation measures, if we do not act in a responsible way and there's any evidence or signs of an outbreak as a result of our behavior and as a result of these new measures. And so persons must be mindful that to ensure continued efforts at restoring normality, it must be done in a measured and responsible way, because we could go back, right back to where we started. And many countries have been in that situation, and we must be very mindful of that. So we have our role to play as a ministry. We have to continue to educate the public, to inform them. We do so individually at a mass level, media and otherwise. We will continue to do that, but a lot of the responsibility is really up to the individual to take the necessary actions. All right.
Chairman, I was...
Any other business?
It's not any other business. I was just going to make a comment on this last matter. And yes, we agree that in terms of the personal responsibility that we expect from everyone to obtain, and also the work of the team, especially the public health team and the contact tracing and the surveillance. But I want to come back to the point that you in as much as you try to de-emphasize the need for the testing, I just want us to ensure that the facilities are there, that when we do find that those who are tested are tested on a timely basis, and that comes back to the whole aspect of getting the kits, and so that is it. So it is important, though it is not the overriding perspective, but is that we need to have that backup facility or that backroom facility, so that when we do the test, we can have the results coming out on a timely basis, so it can inform them as well as the healthcare workers in what direction to take.
And I think the point is well made, and testing will always be an important part of the overall screening process. But again, I say there are limitations to the testing, numbers, limitations. You know, I see where persons are calling for private labs, for example, to be tested. The CMO addressed it. Persons have to be trained, labs have to be accredited. You're not going to get that kind of accreditation done anytime soon. Certainly, maybe not for this crisis. They have to have the equipment. I mean, the accreditation process takes a while. We are training persons in private institutions to collect samples. You don't have a lot of takers for that either. Not many persons want to volunteer for that type of training. So there is going to be a bottleneck if we attempt to do 100% testing, and the risk as opposed to the effort we also have to balance, in that it really is about a more holistic approach to surveillance and management of the process. But point noted, and we will continue, I think, to adjust as necessary while still having the protection of the population as our major focus. All right, so I want to take the opportunity to thank all who are here, and Member Brownberg, who left earlier. Thanks to the ministry team. and to the NHF. I think we have ventilated a number of the issues, and as decided in the earlier part of the meeting, we will monitor the approach to meeting, perhaps not next week, unless there is something very important to discuss. I tell you what, you and I will communicate, member, and if you think there's a need, you give me a call. Otherwise, I'll touch base with you so we can collaborate on both sides of the aisle to ensure that we meet as necessary. And then finally, whether or not we do Zoom versus local, I think we've agreed that we will do Zoom at the next, but at some point we could do local also, face-to-face. All right, thank you very much. Meeting adjourned.